This two-part video series addresses an issue of great importance to patients with complex regional pain syndrome. Do some doctors torture patients with complex regional pain syndrome? Part 1. Evaluation of the patient with complex regional pain syndrome who became paralyzed following surgery.
Okay, Hannah, today is June 18th, 2012, and what we want to do is kind of point out how you got here. We did a ketamine infusion on you, I think it was a 4-day, was it 3-day?
It was 4 days.
4 days.
In October.
On October, which is approximately 7 months ago, something roughly in that range. And we found that we had some significant improvements in you. And it was documented on an objective basis, not only in terms of your pain thresholds, but also in terms of function. Then, shortly thereafter, we had the diagnosis of a gallbladder disorder, which meant clinically that your gallbladder needed to be removed. Okay? You go in to have the surgery, and then I'm going to turn it over here to your mom and tell us what happened at that point.
We followed the precautions that you suggested. We had her on 24 hours of low-dose ketamine infusion in a unit, and frustratingly that
24 milligrams an hour.
No, we did 50 milligrams for 50 an hour for 24 hours.
50 milligrams an hour for 24 hours. Gotcha. Okay, which is a decent dose.
Yeah.
Okay.
And
not high dose, but a decent dose. Go ahead.
Shortly after coming after that, even before leaving the unit, Hannah felt a sudden surge of pain under the incisions.
Point to that, Hannah. It's while your mom's talking. Go ahead.
It was like right here.
Right in there. Okay. Gotcha.
Which very rapidly spread to that right groin, and within hours, the whole of that right leg was numb to the touch, but exceedingly painful, and had no movement at all.
Right. Okay.
We then saw that she got exceedingly unstable and was exhibiting all the signs of being in a seizure that she had no control over. And she would build up in intensity and then literally pass out unconscious. And then the searing pain in her leg would bring her awake, and the whole thing would rinse and repeat for hours on end until we could convince the hospital to get some Ativan into her to try and calm this down. Whilst this was going on, she was unable to breathe, almost as if her ability to physically raise her rib cage to expand her lungs was connected with this lack of movement in her leg. All of this was immediately diagnosed as a psychiatric conversion disorder by the GI doctor in charge of the GI team at that point.
Okay, let's stop for a second here. So, we might want to use this for educational purposes. So let's stop and talk a little bit about what a conversion reaction is. By definition, a conversion reaction means you've got some kind of thing going on, usually a movement disorder. And of course, a seizure-like activity or movement disorder is a movement disorder, okay? But you can't explain it on an organic basis, okay? It doesn't follow the dermatomes, the wiring in the body, and so forth. So a lot of times, what doctors fail to do, and which they did and failed to do in this particular situation, is try to link it to the organic problem that she has. And she was having the allodynia, she was having those things that suggest there was an exacerbation of her RSD because she was wounded. She got traumatized right there in her side, and that's what you would expect. But they didn't have enough knowledge, experience to realize that. So there was a logical, organic basis for a conversion reaction. Conversion reactions are things we see all the time in patients that are subject to extreme pain or emotional stress. And a good example of that is during the Japanese War. They took these prisoners of war, which were men, and they tied piano wires around their testicles and they pulled on them. Well, guess what? When they went to do that to these patients, it was such a stressful situation, they started having seizures, they would pass out, and all kinds of things. It's a protective mechanism, okay? When you're under extreme pain and extreme stress. So these doctors didn't have enough knowledge, enough skill. They just weren't competent enough to recognize that. And unfortunately, when doctors can't figure something out, it's easy for them to say it must be an emotional, it must be purely a psychological thing. And that's unfortunate. Instead of just saying, I don't know what you got, I don't understand it, but they put these labels on these patients, unfortunately. So that's what happened here. All right, go ahead.
We then struggled through a whole week of trying to get enough Ativan into Hannah to keep her stable, fighting this diagnosis, trying to convince them that we thought it was Hannah's RSD reactivating in a different part of her body, the original the original area being Hannah's back, triggered by a lumbar puncture in June of last year. And exactly a week later, the following Saturday, the surgery was done on a Friday, and the first leg went on the Saturday after we withdrew the ketamine. The following Saturday, it transferred to Hannah's other leg, again very quickly. She experienced searing pains up near her groin area, and it spread very rapidly down the whole length of her left leg. So at this point, a week after surgery, she had no movement in either leg.
Mm-hmm. Again, their leading diagnosis was a psychogenic conversion reaction. Am I correct on that?
Correct.
Now, let's turn to Hannah right now. Hannah, do you remember this, what she's talking about, these movement disorders that you had, this jerking and this looked like a seizure but really wasn't? Do you remember any of that?
Not really.
Right. And do you remember, did you have any control over it?
No.
Right. And this is another thing people need to understand, since we're talking about conversion reaction here. You can't control it. It's not something you can control.
Yeah.
It's out of your control, okay? And you're not even aware that it's going on, okay? So that's kind of typical what happened. So let's just say what happened here, clearly what happened here, because I've just examined her, and I can tell you this is all can be explained by an exacerbation of RSD. The decreased pain thresholds she has in the lower extremity, with the left being worse than the right, shows your allodynia. Shows your below this line, anything below this line is felt to her as if I'm tearing on your skin, right? Mm-hmm. We call that road burn sensation, okay? And as you can see, it correlates. Everything's correlating. You can see over here the allodynia is much worse on her right. Remember, it was on her back on the left side. Remember that? Now it's on her right side. And it's dominating down this side of her body. It's a quadrant disease, CRPS. It affects this part. And another thing we need to document here is she's got swelling. That's something we see with RSD, okay? And I did check her out down here. Her deep tendon reflexes are symmetrical, and they're good. I checked her Babinski's, and they're within normal limits, so we don't know, she doesn't have evidence of an upper motor neuron lesion like you might expect with Guillain-Barré or something like that.
Right.
So she doesn't, there's no evidence of that. So this looks like she's got the CRPS, and the conversion reaction is what any normal human being would do when they're put under extreme stress and extreme pain, and it's not something she has no control over whatsoever. We see this a lot in patients that have CRPS, okay?
Yeah.
You're not going to do a conversion reaction while I'm standing here. I'd like to get that documented. Just kidding. Okay, so did we cover mostly the high points? So anyway, you came here in a motor van of some sort because, you know, she couldn't really travel on from Texas. She couldn't travel on a commercial airline. And so the plan here is to do a 4-day ketamine infusion, okay? And again, I want to emphasize the disease presentation now is really quite different than what we started with initially some 7 months ago, okay? And it all correlates with an injury to this part of her body. Show us your beauty marks here. This is where they put they did it by laparoscopic. You can see the little holes they put on you here, which will probably clear up. You probably will notice that later on. But then there was enough trauma down there to set off RSD, and it all correlates with what happened here clearly.
Right.
So I expect her to do well with the ketamine infusion. The question is, how well will she do? I don't know. We'll just have to determine that. Okay?
Yep.
Very good. Any questions by anybody?
No.
How about you, Dad? Anything?
No.
Okay.
Good.
Hannah? Anything? Okay, very good. Oh, by the way, while we're at it, You don't. We can change your mind later, but I'd like to be able to use this for educational purposes, if that's okay with you.
Yep, that's good.
Let's make sure your parents are okay with that.
Yeah.
You okay with that?
Yep.
Okay, good. Okay, Hannah, as I said, we do want to document some functional testing on you. So I want you to take that, first take the, by the way, this is a PICC line they have in you right now. And it looks like it's not sutured in. It's so that's good news. We have to keep an eye on that, you know, for any evidence of infection, that kind of thing. We talked about that risk, so
Yeah.
we're gonna. And you're a nurse, so you know exactly what I'm talking about.
Yeah, you're looking after it
Right,
correctly so far.
right, exactly. What I want you to just take that right hand behind your head, see if you have any pain. Any pain when you do that?
No.
Do the left hand, please. Any pain when you do that?
No.
Remember, when we first treated you some 7 months ago, you'd have some shoulder pain when you did that. Take your right hand, open and close it as fast as you can. Fast. Good, no problems there. Now do the right hand. Left hand. Any problems there?
No.
Okay, excellent. We turn our attention down here to your right leg, which is your worst leg. I want you to see if you can wiggle those toes for me at all. Just give it your best try. I don't see any action there. You getting anything? See if you can bring your knee off the ground here. Can you bring your knee off the bed? No, you can't even move it, can you? All right. I see some muscle contraction up here in your thigh, but just a little bit, but no movement. See right in here, I can try it again. Yeah, see, I can see some contraction there. Okay, now over here on your left side, again, the same thing. Let's do your toes first, so you can wiggle those toes. A little bit of movement there, huh? All right. See if you can wiggle your ankle for me. Can you rotate your ankle at all there? Just a little bit. Okay, very good. See if you can bring that knee off the bed a little bit. Can you do that? All right. And just to summarize, so they can't do it. So just to summarize, from your waist on down, you got allodynia throughout this whole area, correct? Mm-hmm. Real sensitive skin. Okay, very good. So anyway, today's June 22nd, 2012, and this is after your third ketamine infusion. And each day we've been able to get you up to 200 milligrams a day. We can't do that with most people, but for you we're able to do that because
On an expensive date.
That's right. You're right. And what we want to do now, and we still got another infusion to go today, Friday. And then, of course, on Monday, which is 2 to 3 days later, we're going to repeat our measurements on you, okay? So let's take an interim look at you. You haven't been on ketamine since yesterday, so there's no ketamine around, okay? All right, let's start down here where things were really bad. Your worst was your right foot. And I want you to go ahead and rotate your ankle for me. Atta girl. Okay, good. Wiggle your toes for me. Okay, good. Now go ahead and bring your knee up as high as you can. Atta girl. Good. And I want you to do the other one. All right, by the way, did you have any pain when you did that?
No.
Okay, now do this one over here. Wiggle your toes. Good. I'm sorry. Rotate your ankle, best you can. Okay, bring your knee up as best you can. You have any pain when you do that?
No.
Okay. Next thing I want to do here is I'm going to let you pull your little jersey up for a little bit to get. Those are those permanent marks that Dr. Kirkpatrick put on you, right? Mm-hmm. And notice that most of it is over here on your right side, and that's what we would expect. That's where you had your surgery. As a matter of fact, we can see these little scars. You had your gallbladder removed. Okay. And what I want you to do now is I want you to start there. Remember, you know how we test you? Go up there close your eyes. Go up there and work down. See if you can get down without getting that road burn. Any road burn?
Mm-mm.
Okay, that's good. Okay, you do the other side just for comparison. Close your eyes. You get, none there. Okay, good. All right, so that's where we are right now. So we're gonna, like I said, we're gonna repeat all this come Monday. And also, today we're going to do as usual, do your usual pain thresholds, okay?
Okay.
I want to turn to your mom over here. Mom, what have you noticed? I want you to comment on what's going on. You're a nurse. You're pretty observant. In fact, you're super observant, I would add. Go ahead.
Within the first hour of the first infusion, she got the movement back in her feet, and
Right.
that's improved
Right.
as we've gone on through the days, to
Right.
the point that yesterday, after the third infusion, she could walk up the
Right.
steps back into
Right.
the RV we're staying in. The swelling is so much better, and I can tell that objectively from the wraps I'm putting on Hannah's legs to stabilise them, are going further and further round each day.
Right, and you can obviously see that in her feet are not all puffed up like they were before.
Yeah.
Right. Okay. Very good. Now, one of the things, one of the conclusions we can draw right now from a scientific standpoint, this was all due to RSD.
Yeah.
It was all due to the surgery, which traumatized her. It's an injury, right?
Yeah.
Right?
Yeah.
And what the doctors down there said, this is all a psychological problem. This is a psychologically induced conversion reaction, right?
Yeah. Or versus malingering.
Malingering, right, which is not a diagnosis, that's an accusation, isn't
Yeah.
it? So what we can do here is we can say, another conclusion, we can say this is RSD related, and all the doctors that gave all this false and misleading information, they're the ones that got a psychological problem, big time. Wouldn't you agree with me?
It's so frustrating because the last time I checked, malingering can't blow your feet up to twice the normal size, and literally Hannah's legs were paralyzed. When we got here, she had slight movement in 4 toes.
Right,
That was it.
right, exactly. Okay, very good.